This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hello, I'm Dr. Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon in practice in New York City and Wayne, New Jersey.
I'm Marina Kurian, and I'm a general surgeon, and I also do minimally invasive surgery in New York City. And we have a great show planned today, right, Suju?
Oh, absolutely. Today we're going to talk about orthopedics, bones in children and in adults. We have two amazing guests on. We have Dr. Kristin Carroll, who is a professor of orthopedics at the University of Utah and the Sherman S. Coleman Presidential Endowed Chair there, as well as the Chief of Staff at Shriners Hospital. She's a pediatric orthopedic surgeon. And we have Mr. Dr. Simon Fleming, who is an orthopedics resident in the National Health Service in England. He's currently at the Royal London Hospital, and he just took 3 years off of his clinical training to do his PhD. So we're very excited to talk to them about all things bones. Please like and share and tag your friends who would be interested in learning from our guests.
So you guys all know that we also do some news of the week. So there's been some exciting changes this week here in the US, and some of it has to do with masking and what the CDC is currently recommending for travel and for everyone. So we have a couple of graphics on that. It was, exciting for people. I think it's signaling perhaps the light at the end of a very long tunnel. But if you're fully vaccinated, you can be without a mask or physical distancing indoor and outdoor. And that's their newest recommendations. And there's another slide that we have that looks at it a little differently. But, for those of you who like to look at these little graphics, but this is, I think, also well done and shows that if you're fully vaccinated, you don't need to wear a mask together. If someone's low risk, you still can, not wear a mask. But then as you get to people who are higher risk or infected, that you do need to exercise some caution and don't throw away your masks yet. Wash them, keep them. There are going to be still situations where you need them.
Right. So it's not like you can not wear a mask everywhere. If you're traveling in public transportation or an airplane or a train, you still need to be masked. It's very confusing because it just suddenly came out. And certainly if you are exposed to people who cannot be vaccinated or at very high risk, you want to maintain high levels of caution. If you're in an area where the positivity rate for COVID and the positivity rate is very high and the vaccination rate is very low, you want to be more cautious. But this guidelines from the CDC that were announced were based on really good science. And we saw that come into play. So the New York Yankees, which, as we talked about earlier on the show, they test their players, their managers, their staff all the time in Major League Sports. 7 of the coaching staff and support staff tested positive for COVID despite being vaccinated, but that's it. They just tested positive. They didn't get sick and they didn't transmit that disease to anybody else. So that means vaccines work. And so we're very excited about the fact that vaccines are working in real life and not just in the studies. And the CDC also the FDA expanded permission so
for
that
kids
could get vaccinated, right?
Yep. So kids ages 12 to 15 now can get the Pfizer vaccine. They tested it. So this is one of our bigger complaints about the vaccine rollout in the first place, was that certain groups weren't tested. Pregnant women was one. That study came out, and now children ages 12 to 15. And I believe that they think that they're going to extend it to kids even more come the fall, come September. They'll have some greater data that they can share and say that it's okay. But unfortunately, we have the vaccines, and the vaccines seem to be effective against the Brazil variant, the UK variant, and the India variant has been super scary, much more, 50% more transmissible than the other variants. And what they're seeing is that if you were vaccinated, then you had less severe disease. So that is a good thing, but it has been so harrowing and heartbreaking to see all the devastation in India and Nepal, and the lockdowns there are back in. I even have colleagues in Singapore who are going back to a lockdown because they've had 20 cases in the country of the India variant. So they're trying to curtail the spread of that. And so it is of concern, but the good news is that these vaccines seem to be holding up. There's some other good news, though, even better news, because this is actually bad news when we're talking about vaccines. The variants still spreading and causing disease. The good news is a organization called COVAX, and France was the first to donate some of their doses of vaccines to poorer countries, and COVAX is something that is an association of the WHO and Gavi, which is Global Alliance for Vaccines and Immunizations. And they have received billions of dollars, but no actual vaccines now. And so France is donating 100,000 doses of AstraZeneca. Russia and China also plan to send more than 1 billion doses to Africa, Latin America, Turkey, Egypt, Morocco, Balkan states. So there is, big moves of countries that already have a lot of vaccines, sharing the wealth and trying to help other countries, which I think is great.
Yeah, so there are about 11 billion people in the world. About 1 billion vaccines have been done. But I have to say, despite the devastation in India, the news is a little encouraging this morning. Maybe I'm just dying for some good news from India. Over 140 million people have been vaccinated in India. And the 7-day average positivity rate or disease rate has fallen. So maybe they're reaching the end of this horrendous wave. Now, unfortunately, we know, as we found out in the US and UK and other places, the death rate will continue for a while, unfortunately, until that drops. But that is really good news. We are live on Facebook and YouTube and Twitter and Scroll.in and on Sri Srinivasan's LinkedIn page. And we are very excited to introduce our guests today, Marina.
Yeah, absolutely. Again, Kristin Carroll. She is a professor of orthopedic surgery at the University of Utah. She's also chief of staff at Shriners Hospital. And she is a presidential endowed chair, the Sherman S. Coleman Presidential Endowed Chair. There's very few of them in the country, and she happens to be one of them. And Simon Fleming is with us. He is an orthopedic resident in training in the UK, as you heard at, you said it was Royal Hospital.
Yeah.
And Simon's going to be like, you butchered that, but that's fine. Simon, we'll get over it. We'll move past and you can correct us. And then, so we're excited to welcome him as well. He's also a PhD candidate and Twitterati, okay? So if you want to follow him, you certainly can. Welcome. Thank you guys for joining us. We're so happy to have you both.
So thank you so much for being here. Kristin's out in Utah, Simon's in London. We're in New York, and one of our producers is in Hyderabad. So it's quite the crew. Margaret Ambrosino is watching from Vero Beach in Florida. We have people watching from all over, and we thank you so much. Please, if you know anybody who's ever broken a bone, like and share and tag your friends, and this is going to be a great show. Let's start with you, Kristin, Dr. Carroll. You are one of 26 full professors of orthopedics who are women in the United States, and one of a possibly less than 2 handfuls of endowed chairs of orthopedics. You're also chief of staff. So if anybody watches the show Scrubs, she's Dr. Kelso, but really kind and gentle. So Kristin, can you tell us a bit about your journey and the decisions you made?
Mm-hmm. Certainly. Yeah. First of all, it's so great to be here. And it's so great to be here with Marina, because we were friends in medical school and we haven't seen each other in a while. And so it's lovely to see her. So when I got to medical school, I think Marina was pretty set on being a surgeon earlier. And I thought, oh, I'm never going to be a surgeon, because you think of surgeons as you think of them in shows on TV, that they're arrogant and throw things and yell at people. And I was like, I'm way too nice to be a surgeon. I'm not going to be a surgeon. And I went through my 3rd year where you're supposed to choose your specialty, and everything was okay, but nothing did it for me until I scrubbed in a spine surgery, which was the very first surgery I ever did, happened to be an orthopedic surgery. And 5 hours went by, and I looked up at the clock and I realized that I hadn't looked at the clock for 5 hours. And I called my mom and I'm like, hey, I'm going to be an orthopedic surgeon, I think. And she said, well, of course you're going to be an orthopedic surgeon. It's the only doctor you've ever known, because I grew up as an athlete, as many, many orthopedic surgeons do. So I was very blessed to get into my first choice in orthopedics at the University of Utah, which had a very gentlemanly culture. And Dr. Sherman Coleman, who my presidential endowed chair is named after, was one of our chairmen for 25 years. And he spread this incredible culture of inclusivity and diversity way before its time. And so I was very blessed to be able to train there. And when I got to my fellowship, I had just gotten married to a guy who was a flight nurse. That was actually really fun, because everybody asked me what my husband did, and it was really fun to say, oh, he's a nurse, and watch them kind of freak out a little bit. And then I went on and joined the staff there. And in 2014, our chief of staff left and went to Seattle Children's, and sort of people turned around to me and said, well, you're next. You should be the chief of staff. I had no idea that I was going to do that. And I said, the Shrine mission is really important to me. I was working at the Shrine full time at that point. The Shriners Hospital has this long, charitable, incredible history of giving care to children, even if they can't afford it. And there we go. So I stayed as chief of staff and became full professor, and that was it.
You know, I'm also very thrilled that Kristin's here, and she said yes, and it's just so exciting because I miss that face. I smush your face. I really do miss you. But it's for her to calmly and understatedly say she was an athlete. She was a nationally ranked water skier, and just amazing. And yes, she had some injuries. I mean, it's amazing to me that you went to that spine case thinking, I'm not going to like that, because you actually had a spine injury, right?
Yeah.
And
right.
from tricks, water skiing and tricking and jumping and all these things. And I mean, she was ranked 6th in the nation, people. Like, she was just amazing. And then she showed up and we were all like, I mean, I'm just a nerd. I just study. I'm a mental athlete. So, and then on top of it, for her to be so kind and just so, gracious and just a wonderful person and friend. It was just, we really had the best med school class. Sujana and Simon, you guys might think you did, but no, it was.
We did. Yeah.
For this show's purpose, I will allow this.
But it is amazing, and it really is a testament. I think when you said a lot of orthopedists are originally athletes, I think it's a testament to the amount of effort and persistence and practice that you put into your craft, right? That really makes the difference. And you could say that for any field, really, but I do think that there's a lot to be said for that athletic mindset of getting up and having your regimens and doing all the things that you've done. And and obviously it's paid off. And who else should have been chief of staff? You should be chief of staff.
Well, it's a team sport. That's the other thing about ortho. It's a team. Simon's like nodding, I guess. Yes. I mean, it is a team sport. And we work in teams, both in the operating room and on the floor. And I think that's what we really enjoy. It's a very social event, orthopedics. And we talk to each other a lot, trying to get information from each other. And I like that about it.
So, I think you saying that, 5 hours flew by and you had no idea. That's what I tell the medical students. I'm like, keep your mind open, keep your heart open, because you will find the part that brings you joy, right? So I love that you said that. Simon, what was your journey? And I must say, people watching might say there are 3 like people and 1 unlike person here, but I think Simon is possibly one of the biggest feminists I've ever read from or heard about. So I follow him on Twitter and a bit of a fangirl. And I think, you've focused not just on orthopedics, which is amazing in and of itself, but also on improving medical education so that people who are other don't feel like they won't belong in whatever they choose. So maybe you can talk to us about your journey.
Yeah, I mean, I did my undergrad, my medical studies in London in the UK, and I worked out pretty quickly that I wasn't a physician. It didn't inspire me, and I was kind of looking for that moment of, like what sparks joy. And I was in the Royal London Hospital, which is our big trauma unit, our major trauma centre for London, and I was in the Royal London as an undergrad medical student on the July 7th terrorist attacks. So all hell breaks loose, and people are running around, and most of my year, quite sensibly, either left or stepped out. But I kind of went up to the emergency room and said, "How can I help? I'm a 4th year medical student. What can I do?" And they were like, "Look, we need some people to push patients around and maybe take some blood, like make yourself useful." And when I was running around, there was like this corner of calm in the emergency room, and there was this group of people, and I kind of said, "Who are they?" And everyone was like, "Oh, those are the trauma surgeons." And I was like, "What does that mean?" And they were like, "Well, that's orthopedics, vascular surgery, and plastic surgery, like bones, blood vessels, and bums, basically." And I was like, they just look so calm and collected, and like Kristin said, like they're working as a team and they're making decisions, and they're just like, "How can I help? What can I do?" And I was like, that's what I want to do. And when you try and get into medical school and they ask, why do you want to be a doctor? Everyone says, "Oh, I like science and I want to help people." And what I realized is, I like science, right? Total nerd, but my kind of I want to help people is different. I want to fix people. I like having a problem, and then I like sitting down with people and being like, "We've got a problem. How do we fix this? How do we make this better?" And so even as a more junior doctor, I would see these people come in and they can't walk and they can't use their arm and they can't do this and they're in pain, and then orthopedics would do something and then they're better. They're using their arm, they're back to work, they're pain-free. And I was like, I want a piece of that. But the more I looked around, the more every now and then there would be these kind of discordant notes, these moments that just didn't seem right in this world, in this community that I loved. And I realized it was the culture. And I get it, right? The elephant in the room is that I am a straight, white, rugby-playing, private school educated heterosexual male. But power and privilege is like electricity or magic or the force, right? It's not good or bad. It's just what you do with it. And so I decided to do something about it, and have spent the last couple of years very loudly and sometimes less loudly just trying to make stuff better, because we know that if you have a more diverse, inclusive, respectful workplace culture, your team performs better, you perform better, and it means your patients do better. So it just makes sense. The old boys club, just wasn't a great business model. It was how it was, but we now know better, and it's why this kind of work is important to me and keeps me busy.
Simon, in the U.S., 6% of practicing orthopedic surgeons are women, and 15% are trainees. So that's good, because people have seen doctors like Kristin Carroll and said, "Hey, I want to do this," and are moving up, and that's wonderful. What's it like in the UK? Is it similar, or is it really less percentage or more?
Yeah, so our numbers are better, but not the best. So our numbers are in the US, like you said, the numbers are about 6%. In the UK, it's about 6.97% for attendings for fully qualified surgeons. And again, for our residents, our numbers are slightly higher. They're about 20 something. And again, it's in the last 5 to 8 years, we've made a real push about, and not just focusing on gender, though it's an obvious target and an important one, but just all forms of diversity. You know, you can't represent your population if your entire workforce is a bunch of white guys. It's not a thing. But you know, there's still a lot of work to do, and we see that not just in the numbers, because the numbers are easy to chase, but then you run the risk of getting into kind of tokenism, like, oh my god, we need 5 more white women, a disabled person, and then we've done our job for the year. And it's much more about changing the way we do everything, and recognizing that some of these systems, because of the nature of it is what it is, you know, one of my favorite phrases is the system isn't broken, it was built that way. You know, so some of these systems were designed by reasonably wealthy white men to support reasonably wealthy younger white men. And so, you know, when you think about work experience to get into medical school, the system still heavily relies on who you know. And so if you're not middle class, and if you don't know loads of doctors, you're going to struggle to get work experience. You know, there's all these little things we're working on to try and make our workforce more diverse from a characteristic point of view, but also from a diversity of thought point of view. You know, some of the great ortho stuff we do is because someone said, yeah, but why do we do that? Why don't we do it differently?
Yeah. You know, we have people watching, as I said, from all over the world. Lakshmi Ramanathan is watching from California. Vijay Sundaram is watching from Ottawa, Canada. Bernard West is watching from Dubai in the United Arab Emirates. Thank you all for tuning in. We could devote a whole show to this, but we are going to talk about broken bones and things that happen. Let's start with children. So, Kristin, can we talk about, you know, yesterday my friend, my cousin, she's some mix of those, you know, told me that her son had fallen off his hoverboard and broken something, and there's a picture of him with a cast on. So let's talk about common pediatric orthopedic injuries.
Sure. So certainly forearm fractures are the running favorite for kids. And, you know, lots and lots of kids break bones. And the beautiful thing about children is they have magical healing powers, which is, I think, why some of us chose peds to start with. They don't get things called non-unions very often, which are where bones just won't heal, even though they're treated appropriately. They don't get infections as often. And, you know, they just want to get well and get out and run again. And that's such a beautiful thing about pediatric orthopedics. So certainly children are treated with casting much more often than adults, although there are fractures, especially fractures that involve a growth plate or go into a joint, that may require operative fixation with pins or screws or plates. But incredibly, most of the stuff we can treat with casting. Because kids do heal so well. So a classic example, a tibia fracture, so your shin bone, okay? So adults like us would take 17 to 20 weeks to heal that. An 8-year-old can do it in 6 to 8 weeks, and a baby can do it in 3.
Wow.
Just it's phenomenal how much different the healing potential is in a growing bone and in a growing skeleton. They're also more forgiving because since they are growing, they can also change if something isn't perfectly lined up. Bones actually perceive stress. And so they can adapt to stress to straighten themselves out as they grow, which is another beautiful thing about peds.
When I have a couple of things, because my kids, when they were growing, all of a sudden they'd be crying at night. And I go in there, I'm like, what's going on? My foot hurts. I'm looking at the foot or their shin, and I'm like, okay, I'm gonna get you some Advil, get you something to drink, and then I don't know. But it was growing pains, and their dad had that as well. So just talk a little bit. What's actually happening?
So I get that a lot, actually. Growing pains are very, very common. They do run in families. They're most commonly bilateral, meaning both extremities, and most commonly in the lower extremities, especially in the shin and the foot. And usually the kid is asking, please rub my foot, please rub my shin. One thing that we have found in this country is that a number of our children have low vitamin D. It's, we slather our kids up with sunscreen, which we should, to protect their skin, but then it affects their vitamin D becoming active with sunlight. So we have found, especially in our children with other syndromes like cerebral palsy or other issues, their vitamin D can be low in 75%. So I've had a lot of my families have their kids feeling better by increasing their vitamin D, which you can do with like a vitamin D gummy. Just make sure they get 1,000 units a day, and that can definitely help. But I wish I had a perfect answer to growing pains. I don't. But certainly things that should concern a parent are if the pain is always in one limb instead of two, that's unusual. If the child is having night sweats, or the child's appetite is changing, or they're losing weight, those are things that don't go along with growing pains. Growing pains happen in normal kids who are growing. And kids grow at night, interestingly. They don't grow during the day very much. So you think about that tibia or whatever is growing like crazy, and all those nerves and arteries have to go along for the ride. And that's what usually gives the aching sensation.
So, that the graphic we put up earlier said 50% of children will break a bone during their childhood. And Simon's response in our private chat was, trampolines are evil. So Simon,
Yes.
Can you talk to us about, we want our kids to play, and certainly with this pandemic, boy, oh boy, do we want our kids to go somewhere else and play.
I know you're not going to know the answer to this, but if you do, that's great. But haven't you seen those videos of the dogs bouncing on the trampoline too? I wonder
And
if
the sheep.
Yeah, but I'm not a vet, so it's fine. I mean, you're absolutely right. And the trampoline comment kind of links in a little bit with what Kristin was saying about growing pains. It's about expectation management and kind of, I hate to use the phrase common sense, but it's about, this is normal, this is safe, this is just part of growing up. Like breaking bones is part of growing up. Rough play is part of growing up. Falling over and hurting yourself is part of growing up. We shouldn't wrap our kids up in cotton wool. On the other hand, a bit like with the growing pains, when you warn parents, this should get better, but this is what you should look out for. Having a kid on a trampoline is fine. They have the special side supports and blah, 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 blah. Having your 2-year-old on the trampoline with your 4-year-old on the trampoline with dad on the trampoline is less fine. Mm-hmm. And that's the thing, is trampolines in and of themselves aren't dangerous, but misuse of trampolines has been identified as a significant cause of pediatric injury globally. Because it used to be that you had to go to special trampoline parks and be supervised, and it was a thing you did in a gym, and now you can buy one. And it's and often the injury is either a kid unsupervised or lots of kids on the trampoline together, often with bigger kids or adults. And that's where you get that's where I get anxious.
Yeah. Right. It's like the tiddlywinks factor, right? So the little one goes flying off, right? When the big one is jumping. And that's where things become dangerous. Trampolines are actually huge in Utah, and kids, as there are a lot of children in Utah, a lot. So there's actually a trampoline fracture, which is where the trampoline bounces back, is rebounding up as the child is coming down, and it causes a compression fracture of the top of the shin bone, which can then cause growth disturbance later on. So it is a real concern, and I'm all for kids being active, and trying to avoid childhood obesity, which is another terrible problem. I'm all for it, but little teeny bunkers should not be on the trampoline with big bunkers. That's basically it.
Yeah.
So Miriam Berkeley is watching and asks, what percentage of children experience growing pains? And we have Ahmad. See, I had his name up and now I've lost his name. Give me 1 second. Ahmad Shadab is watching, and I don't know where he's watching from. Ermine Hero is watching from Finland. I think you guys are giving a lot of us a lot of information we need.
Kristin, what percentage of the kids actually get it?
Yeah, so that's not exactly known because some people don't even report it, right? So we don't know exactly what this is, but it's probably in the 3 to 5% and maybe even as high as 10 because of underreporting.
That's great. Simon, let's shift gears a little bit. Let's talk about common orthopedic issues in adults. So we have a list of some common things that are described that you must see in your clinics. I didn't realize that torn meniscus would be so high on there. And some of the others are obviously repetitive injury, like carpal tunnel, where you're working and that's like a repetitive injury. But let's discuss a little bit some of these things, and then we do want to talk to you about joint replacements because it's such a big deal.
Yeah, I mean, trauma in orthopedics, it kind of gets divided into two things, right? You have trauma, people break stuff, damage stuff, tear stuff, and then you have orthopedics, which is the more planned, elective, wear and tear side of work. In terms of torn meniscus, yeah, we see a lot of it actually. So the meniscus is a shock absorber. It lives between your shin bone and your thigh bone, and you've got one on the inside of your knee and one of the outside of your knee, and it takes about 50% of the weight-bearing load when your leg is straight, and about 80% of the weight-bearing load when your leg is bent. So it's a really important structure, but as you might imagine, it's got the consistency of a shock absorber as well. So it's kind of squidgy, like an eraser you would use in school. And it's made of kind of cartilage and water and collagen, all that sort of stuff. However, it's really easy to damage, especially in people who play a lot of sports. And often you'll hear people say, I was running for a football and I turned suddenly and I felt a click or I felt a pop. Equally, you might hear someone say, I was just getting out of bed or I was just walking up the stairs, and you never quite know, depending on where you've torn it and how you've torn it. The classic symptom is what we call mechanical symptoms, and this is where people accuse us of being kind of carpenters or mechanics. So the classic symptom of a torn shock absorber is locking. So that's where your knee either won't straighten or won't bend; it just catches. And a clicking noise, especially if you're kind of squatting, if you're bending down. And often they'll swell up. And when you see your physician, they'll ask you, did it swell up immediately or did it swell up after a little delay? And then your physician will wiggle you around and get some scans potentially, and they'll decide what to do. Now, the great thing about orthopedics, and this comes back to the team sport thing, is that the management of a lot of these conditions, torn meniscus, problems with your shoulder, problems with your wrist, all of those things, often, unless it's really bad or unless it's a trauma, often our first line is non-operative management. There's a lot of sayings about surgeons, and I'm sure I'm not the first person to say this on here, but a really good surgeon knows when not to operate. And so in the early stages of management of these conditions, we will involve our colleagues in the physiotherapy department, and we will rehabilitate the patient. And it's the same for shoulder. It's the same for carpal tunnel. And actually, we know that there's quite a lot of improvement in most people with some decent physiotherapy. If that doesn't work, then you can talk about the operative management, and that's when we start talking about kind of keyhole surgery in the knee, which can work really nicely. And those are ones that basically don't do well with physio, and either you can't or don't want to repair. But about 80% of people who have their surgery say, yeah, you know what, I'm happy I had it done. Because often, again, it's all relative. So they've had a knee that doesn't do what they want, how they want, for as long as they want, and now they can. And that's after this, I'm giving a talk to people, trying to convince them to be orthopedic surgeons. And one of the best things to say is we've been shown multiple times, orthopedics has been shown multiple times to basically be the number one intervention that has the largest impact on sustained quality of life. So someone comes in and says, I'm sad, I'm miserable, I'm in pain all the time, I can't do the things that bring me joy, whether it's gardening or walking or whatever, or standing up from a chair. And we do stuff in adult orthopedics, and we give them back that quality of life, whether it's fewer painkillers or back to work or can play with their grandkids or can go back on the football pitch.
One of the things that they talk about in terms of longevity, right, and is about that quality of life and that mobility, that you don't want to lose your mobility and that you have some flexibility. We should all be stretching and walking and doing all that so that we can have a wonderful quality of life when we hit our 80s and 90s, which is going to happen, I think.
Yeah. And that's the thing, is our population are living longer and longer. So we're going to be seeing more and more of the kind of degenerative is such an emotive term because it sounds like you're falling apart. But when I'm in my clinic and I speak to patients, I generally do use a car metaphor because people understand it. And it's like, look, my dad had a car that he had for like 25, 30 years. But he replaced the tires how many times and the brake pads how many times and the washer fluid it's still his car. But every now and then things wear out, and sometimes they're okay and you can leave them be, and sometimes you need to replace them. And that's what
can I ask you, what is a knee replacement? Like, people say knee replacement. Do you like just take out like a humerus and a tibia, or a femur and a tibia and fibula, and just chuck them in? Or what is a knee replacement surgery?
Yeah, so commonly done for arthritis, which is again a degenerative condition. You have cartilage on your joints, in your knee and your hip, and it's a slippery surface that helps your knee or your hip move nicely. And if you get wear and tear, if you get this disease, and it is a disease, osteoarthritis, because it's more wear and tear than you would see normally. And that's the point. It's a significant disease. The FDA have recognized now that it's a significant disease. And so you see on that picture, you get wear and tear, and that wear and tear causes pain. Sometimes terrible pain. And there was a paper published recently because of the pandemic talking about orthopedic patients who've not been able to have their surgery because of COVID, saying that they would rather die than have their arthritis pain. And of course, in the early stages, it's not that bad. In the early stages, it's physiotherapy and painkillers, right? Like every condition. But sometimes, at some point, you get to the stage where you need to do something about it. And a knee replacement or a hip replacement is a pain-relieving operation. That's the most important thing. And so without being too gruesome, we cut out the arthritis. We use tools to remove the arthritis, and we replace it with metal and plastic, and sometimes ceramics as well, because there is nothing as good as the body you were born with, but we can come a close second with some of the stuff we can make in factories. And,
Simon, yeah. Nina Yashvi has a question about, and this is actually something that all of us can relate to. But she's saying she's struggling, knee replacement. What could she have done as a female surgeon to avoid it? Like, we are standing, and I have this position. One leg is free to use the electrocautery. Okay, so that's and then basically I put all my weight on the other leg, and I'll operate like that for an hour and a half to 2 hours. So, I mean, I shift a little bit, but when I get done, I'm crooked. I feel like I'm like in one way, and I step down, and my knee that was locked in position is like, hello, and I get down from my step, and they're like, everyone's like, what happened? I'm like, well, my knees just been locked for an hour and a half, and I just finally moved it. It hurts.
I mean, surgeons are terrible for it, right? Yeah. I don't know any surgeons who don't have a bad back or a bad shoulder or a bad knee. There's loads of stuff you can do, and again, it comes back to really sensible stuff, right? So trying to stay fit and healthy, right? Trying to eat a balanced diet and staying active outside of the workplace. In the workplace, whether you are a surgeon or you work in an office, making sure that you have a decent posture and you have the right chair and all that kind of stuff that when you start at work and the person from HR goes, this is how you lift boxes properly. Like, it matters. Like, taking care of yourself matters. And when you start to get symptoms, the best thing to do is to see a doctor, because prevention is always better than cure with these things. And
right. I was talking with some people about ergonomics, because ear surgeons, so we sit, but we're hunched over and we're, everything is just wrong, right? So we're really talking about ergonomics and about maximizing our comfort so that patients do well over the course of our careers, and so that we do well over the course of our careers. And one of the anesthesiologists was telling me that she actually stops the surgery at intervals and makes everybody do chair yoga for a minute or two. So Kristin, I wonder if you have some experience of how you manage to keep limber with an athlete's conditioning when you're doing these long cases, long work days.
What Simon said is totally important. It's generalized health, of course, out of the operating room is very important. And weight gain is obviously a huge deal because every step you take through your hip, for example, because of the joint reactive forces, which is the power of all the muscles working around the hip joint, every step you take is 3 times your body weight. So any rise in body weight, you can see how it really impacts your hip because it gets multiplied times 3. Anyway, so I think one thing is standing with one leg bent, one leg straight takes off the low back strain, which is great. Using stockings so that you don't get, too much swelling in your legs with long standing is important. And certainly being aware of your core and keeping that as sound as you can while you're operating is also important.
Yeah, I try. When I'm operating, I have the laparoscope is always right by my belly, and the resident or whoever's holding it, I'm like, have to pull in my core because I'm like, okay, I know. It's a constant reminder, like it just nudges past my belly. I'm like, pull in your core. So it's less resistance, so they can actually show you what you need to see. So it's a constant thing, but it is important to have that core and maintain. You're absolutely right, both of you. Kristin, let's talk a little bit about athletic injuries in kids. Okay, so you're in Salt Lake, and I hear the summers in the mountains are even better than the winters. I've only actually been there in the winter, so and in addition to ski injuries, but there's going to be bike injuries and things like that. We have a couple of slides talking about what a growth plate is. So if you could start with that, and
Sure.
You had made mention of it, and then we can talk about all the different types of physies.
Sure.
Whatever, you got it.
So so the growth plates are these magical, amazing things that live at the end of your long bones. They close in puberty. Your rise in testosterone or estrogen makes them close, and that's why we stop growing in height. But while they are open, they are cartilaginous plates made up of rows and columns of cells that literally displace one cell layer at a time to make us longer one cell layer at a time. And they are important, obviously, because if there is an injury to the growth plate, it may affect how the bone then grows going forward if there's a permanent injury to the growth plate. So if one side of the growth plate is injured, the other side is not. The side that's uninjured will grow normally. The side that is injured may not grow as quickly, which can cause a problem with angle, where the normal side grows faster than the injured side. Or if there's a complete arrest all the way across the growth plate, it will cause either a limb length inequality or an inequality in the upper extremities. Luckily, there are, so this is great. This is the Salter-Harris classification. We use this all the time. And basically, going from a 1 to a 5 goes through the severity of the injury. And 1s are through the growth plate only. You can't even actually see the fracture on x-ray. You can see it as it's healing. 2 goes through sort of the wide part of the bone down in. And then a 3 and a 4 become more severe because they involve the joint. The growth plate starts on the joint side. That's where the cells come from. So not only is a growth plate injury more severe if it goes into the joint, because then the joint is affected, which can lead to arthritis, like Simon was talking about, but also it can affect where the growth plate comes from, the germinal layer of cells, which can then affect how it works in the future. So these are very, very common, and there are some growth plates that can take a joke, and there are some that cannot. Luckily, the most common injury in kids is in their forearm and their wrist. And the wrist growth plate, both at the radius and the ulna, the end bones, one by your thumb, one by your little finger, are very tolerant of growth plate injury. That doesn't mean they never cause an effect, but it's much more rare. whereas the growth plate at the end of your femur bone is much more sensitive to injury. Luckily, it takes a lot more energy to injure the femur, so that doesn't happen as often. But we see these all the time.
And the femur is the thigh bone, right?
Somebody has to have operative intervention versus just being treated with a cast.
And just to say, the femur is in fact the thigh bone, right?
Oh, I'm so sorry. Yes, the thigh bone, above the knee. Thanks.
No worries. It's because, I said it wrong earlier where I said humerus instead of femur because, what do I know? But I think these are really important because people, if 50% of kids are getting fractures, that's really scary. Like my friend whose child fractured near their wrist, what I'm hearing is that it's likely with a cast and with maybe vitamin D that they will have full normal function.
Yes.
Right, because that
is the rule in general more than the exception in pediatrics. And kids are just remarkably resilient, and in general, we can get them back to being as normal as possible. Obviously, with the severity of the injury, the higher the energy of the trauma, a car accident is different than falling down on your arm as you're riding a bike. Those things are different, but in general, kids have remarkable healing potential. Yes.
I think my favorite thing you said was vitamin D gummies. That's like, I think that's wonderful because who doesn't want a gummy? People
who doesn't?
Yeah. There's gummy fiber. Just take. That's great.
Exactly. We have a question. You said children do bounce back, and Sumana Rangachar said, her daughter and the daughter's cousin were playing horse and the daughter fell off and there was the broken upper arm there. I think that the level of injuries and the level of bounce back is so different in adults and children. We're doing a lot of, or you guys are offering, Simon, a lot of knee replacements and hip replacements in older adults. So how do they maximize their recovery? How successful are these operations as we get older, and how do they maximize return of function?
That's a great question. And what it comes down to is it used to be that very much you came into hospital, you had your knee replacement, your hip replacement, and that was it. You were done. And now we've realized again that it's about that team sport. So we do stuff called prehab. So before you even have your knee or your hip replacement, you start your physiotherapy. You start to build up the muscles that we know are probably weak because you've been not walking as much, not doing as much, but also the muscles that we're going to make weaker still because you're going to have an incision in them and maybe need some time in hospital. And we build you up. And while you're doing that, you want to do a lot of expectation management. And again, really good evidence that if you know what's coming and you as the patient feel part of that process, you'll do better. People do less well when stuff is done to them, at them. Whereas if they're part of the team and the patient is part of the team, they do better. And then obviously the day of the surgery, it's about all of us doing our jobs right. And then post-op, and I always say this to my patients, I'm like, I do the easy bit. It's people IKEA, it's flat pack. I'm going to take your arthritis away. And it's the day after surgery that the hard work really starts. Mm-hmm. That's when the rehab starts. That's when the physiotherapy starts, building up the muscles, getting back to activities. Again, all that fitness and health stuff. And we support our patients in doing that as best we can, again, with physiotherapy, occupational therapy. So people who talk about how to either go back to what you used to do or modify your life so that you can do something like it or similar to it.
Simon, what do you think about doing both at one time? Like who qualifies to do both knees or both hips at the same time? Or how to make that decision?
So I'm going to do that full shameless disclaimer that I get to do, which is I get to say that I'm a resident. So but saying that, I think you have to have a discussion with the patient about what they want and what they expect. I think the best evidence is that doing both at the same time, though it obviously means one hospital stay, is a much bigger hit than what it appears to be. It's not like, I'm just doing one big operation or even two medium operations. It's a very big surgical insult. Like your body takes a really big hit. And as you might imagine, because you've got 2 sore legs, your rehab is slightly slower. It's very much a patient and surgeon discussion.
Right.
But a bit like, so when I do carpal tunnel surgery, right, which most people think of as quite a small operation, and patients go, look, why can't you just do both? You've said that it's a 10-minute operation, so why don't I have a 20-minute operation? And it's the same thing. You go, well, if I do both, who's going to wipe your bottom? How are you going to, how are you going to comb your hair or brush your teeth? And they go, oh yeah. I'm like, why not have one 10-minute operation, get better, and then come back? And we're seeing the same with joint replacement as well.
And Simon, I don't know how it is in the UK, but for us in the US, I mean, I had a partial total knee done last January. I did clinic in the morning. I went into the hospital at 2. I was home by 7. And I was back at work 3 days later. I mean, it's phenomenal, the difference in that prehab and how quickly it helped me get back. It's orthopedics is totally changing. And it used to be that we would bring a kid in or an adult in for a total hip, they'd stay for a week. And people are having this done in an ambulatory fashion now. And that's wonderful because people do better in their own homes than they do in the hospital. That's always true. But the prehab is really important to that.
And that is something that we've actually taken from you guys. And in any abdominal wall surgery now or hernia, we're trying to get our patients into, whether it's respiratory breathing mechanics or just increasing their activity, we are all about prehab, and we learned that from you. Kristin, there's a question from Chris Ramanathan. It's an interesting question about whether children playing one sport all the time or playing different sports, sort of that whole cross-training mentality. What do you see? Is it more serious injuries if you're only doing one sport, or is it the combo that's an issue?
So injuries can happen in any.
Before you answer, Kristin, I was actually talking to somebody whose kid plays baseball year round and had Tommy John surgery at the age of 12. So I think this is a real concern as children are very aggressive about the sports that they're playing.
Absolutely. So, injury can happen in any sport at any time. But what happens when you play the same sport over and over and over is more of an overuse injury. And that is much more common if you're doing just one sport. Throwing sports, for example, and the kids get shoulder and elbow problems that may not have happened if they had been doing a throwing sport at one season and then soccer in another season. So we're definitely seeing that kids who are focused only on one sport, especially when one sport has so many repetitive motions, not all sports are like that, but certainly there are some that have a lot of repetitive motion. That those definitely are affecting the growing skeleton. So I would say cross-training is great, and doing more than one sport is great. But certainly we know that there are those kids who just love their one sport, and that's when, certainly sport physio, like Simon was talking about, physio is everything, and throwing skill and how to do that appropriately and not dangerously becomes very important.
There are other problems that we see that I'm sure that orthopedics practitioners get consulted about. So my kid has knock knees, my kid has bow legs, my kid kind of walks funny. What is of importance in that? I remember my third son is very pigeon-toed, and the pediatrician said to me, "Oh, he'll be a great runner." Well, he's a mental athlete, like Marina.
Like Marina.
But, so when do we get concerned, and when do we not?
So there are things that are normal during the development of kids, just like crawling is a phase, only being able to sit is a phase, then you're able to walk, right? So knock knees and bow legs are like that. Being bow-legged is pretty normal till 2.5 to 3. After 3, that really should be going away. And if it isn't going away, that's when I would ask for help. Knock knees are also very, very common. And they kind of hit a peak around 8, 9. But if after 8 or 9, that child is still very knock-kneed, that may be a good time to ask for help. In-toeing and out-toeing, I get questions about all the time. and in-toeing and out-toeing are also very, very common. The tibia, which is the shin bone, has inward rotation often, usually secondary to intrauterine positioning because the baby sits intrautero like this. That corrects usually by age 7. But inward rotation that comes from the hip, when you see little girls who are W sitting, and I say girls just because it's more common in them, boys can do it too, who W sit, where they sit with their legs splayed out to the side, W, that's caused from inward rotation of the hip, which doesn't correct until 10 or 11. So most of these inward-outward rotation, bow legs, knock knees, should kind of be over by 10. But the one thing I would say is bow-leggedness really should be gone by 3. And if the child is still significantly bow-legged after that, that can be a sign of other things, like problems with growth of the bone or vitamin D deficiency or rickets, those kind of things. So that would be something I would check on earlier, bow-legged after 3.
So is there a time where it's too late, where we've consulted the orthopedic surgeon too late?
Yeah, so there's this beautiful thing in pediatric orthopedics where we can manipulate the growth plate to correct angular deformity. So if someone has knock knees, it's as if the inside of the knee is too long and the outside is too short. And you can actually put a small plate that brackets the growth plate on the long side of the knee. And as the child grows, they can correct themselves. That's awesome because then you don't have to cut the bone to correct the deformity. So that is something that you want to do while the child is still growing. And so in girls, that's before puberty, before menses, and in boys, it's usually before 14. And that would be wonderful to be able to see them at that time so you could do this easier intervention to correct their angular deformity.
Well, guys, we are going to, sadly, this really flew by, and want to thank both of you for your expertise. Simon and Kristin, we're going to ask you for some 3 toys for our viewers. So Simon, you first. Things that you want people to do, don't do.
I suppose my first thing is if you have problems with your joints or your bones in particular, I would want you to go and see your doctor early. I am much more happy seeing patients and telling them that they're going to be okay and they just need to see their physiotherapy than having to have a conversation about an operation. So if you're starting to get pains in your joints and all that sort of stuff, see your doctor, see a physio, get assessed early. I would probably take home is that knee replacements and hip replacements are scary, but they're probably one of the best operations in the world for getting people back to their quality of life. So if you need one, don't be afraid. This is what we do day in, day out. And for anyone watching who's considering a career in surgery, I guess the take home would be come and have a play, because we are looking for every single kind of person from every single walk of life to come and join the team.
That's wonderful. Kristin, how about your 3 takeaways?
So I'm going to borrow Simon's last one as the first one. I'm chair of our Equity, Diversity, and Inclusion Committee at the University of Utah for ortho. I totally reiterate that. And it's a wonderful specialty because orthopedics is one specialty where the organ system you're working on regenerates. It actually gets better. And that makes it a wonderfully positive experience. Number 2, so pediatric orthopedists are super sweet, lovely people. We love to see children early, just like Simon said. And certainly if you have bow legs after age 3, please get that checked out. The other thing is just caution with children. So 1 child at once on the trampoline, children under 10 outside if you're mowing the grass. Please don't put your child on your riding lawnmower. These are tragic injuries that are very difficult to overcome, both for the child as well as the family.
Wow. Thank you both so much. We have been honored to have Dr. Kristin Carroll, who is professor and chair and endowed chair of orthopedics at the University of Utah and Shriners Children's Hospital in Salt Lake City, Utah, and Simon Fleming, who is an orthopedic resident and PhD candidate at the National Health Service in London. We have really enjoyed this time with you. Thank you guys so much for joining us today. Marina, I want to thank our producers.
Yeah, so we can't do the show without these wonderful people who join us, and I want to thank our producers, as you can see on this slide. And then in addition, we have a great show next week. It's going to be, unfortunately, we still have to talk about it, all about COVID. And our guest will be Dr. Anne Felicia Ambrose, who's a physical medicine and rehab doctor and an associate professor at Montefiore in the Bronx, and Dr. Elizabeth Parfit, who's an infectious disease physician in British Columbia and Canada. And we're going to be joined by them next week.
So have a great week, you guys. Stay safe. Only one at a time on the trampoline.